Okay, so we're at 7 o'clock. We're going to go ahead and start our program. And first of all, I'd like to welcome everybody to Brain 101. We have over 230 registrants, so I'm excited about today and about the next six sessions, all of which will be Tuesday nights, as people know, from 7 to 8 o'clock at night. So I'd like to start off by having everybody imagine that this is the first day of the first week of their first year of medical school. So you're all sitting in a great big auditorium, and you're scared to death. You're scared to death because it's your first day of medical school, but you're also scared to death because all of the upperclassmen have told you that the worst course, the most difficult course in all of your medical school training is the neurosciences. And on top of that, one of the most difficult things is brain anatomy. Now, after all, who understands the brain anyways? So over the next 6 weeks, we're going to try to structure these talks as if you're a first-year medical student. We've asked the speakers to kind of design their talks at that level. Now, understandably, it could be a little bit above some people's heads, a little bit of a challenge, but everybody likes a challenge. So I think that this is going to be a lot of fun. Just to give kind of an overview, this is our curriculum for the 6 weeks. We're going to start out with an introduction to brain anatomy by Dr. Ojemann, and I'm going to announce Dr. Ojemann a little bit later here as he gets started. So that'll be today. Next week, we're going to have an introduction to stroke and traumatic brain injury by Sharon Poisson and Christopher Rourke. Sharon is head of the stroke program here at the university, and Dr. Rourke is one of our interventional neuroradiology colleagues and a neurosurgeon. And then we're going to finish the hour off with a traumatic brain injury 101, an overview by Dr. Delia Bakeman, a real expert in traumatic brain injury. The following week, we're going to do an introduction to brain tumors and neuro-oncology by myself and Dr. Denise Domick, who's one of our neuro-oncologists. Then we'll follow that with an introduction to neurodegeneration and Alzheimer's disease. Dr. Huntington Potter is head of the Alzheimer's Center at the university, and he's going to be talking with Dr. Peter Pressman about Alzheimer's and neurodegeneration in general. The fifth week, we'll have an introduction to movement disorder and neuroengineering, and this will be kind of a bit exciting. This is the brain-computer interface work, and I think a lot of you have heard about Neuralink and Elon Musk. This is kind of that same area that we're going to be talking about, and we'll be talking also about deep brain stimulation. Alex Baumgartner talking about Parkinson's disease. And then the last lecture will be on an introduction to psychiatry and substance abuse science. Now, after all of that, we're going to have a final exam. Everybody's got to pass the final exam. I'm just kidding. But we will have a optional graduation and a breakfast session on June 1st. Everybody's invited if they'd like to come, and we will be handing out certificates at that time. So this has been but also by the Neuroscience Innovation Initiative. So a lot of you probably don't know, about 80% of the research that's currently being done on the Anschutz campus is in some way or another related to the neurosciences. Between the Anschutz campus and the Boulder campus, there's over 200 independent investigators working on the neurosciences. Yet, we don't have a overseeing neuroscience institute. So until we had that institute, several years ago, we developed the Neuroscience Innovation Initiative. And the mission of that initiative is to comprehensively and strategically integrate the clinical and research aspects of neurosciences on the Anschutz campus and beyond, to foster collaboration across departments, divisions, and campuses to build research opportunities, particularly in translational science, to vigorously communicate the work of the neurosciences across the CU campuses, the local region, and the entire nation. I've got a little slide kind of down on the right-hand corner. It's a little bit small, but it just kind of tells you all the programs that are involved in neurosciences and bringing all of those programs together. So the initiative basically has 7 broad program areas, and we're going to be, the talks over the next 6 weeks are going to touch on each one of these areas. Neurodegeneration disorders in the aging brain, kind of aging across the lifespan, neuroengineering and human device interface, brain and spinal cord in neuro-oncology, neuroimmunology and neurovirology, neuroinjury, traumatic brain injury, spinal cord injury, stroke, also repair and rehabilitation, and neurocircuitry. When the circuit goes bad in the brain, the electrical circuit, you get epilepsy, but you also can lead to addiction and other psychiatric disorders. So I failed to introduce myself. I'm Kevin Lillihigh. I'm chair of the Department of Neurosurgery, and I'm going to host this along with Tammy Lack, who you see up there. Tammy is head of strategic development for the neurosurgery department, but she's also executive director of the Neuroscience Innovation Initiative. So a little bit of housekeeping before we go on to Dr. Ojemann's lecture. Because we have so many people on the chat, on this Zoom, we like to allow about 10 minutes at the end of the session for people to ask questions. And the way to do that is if you look at the bottom of your Zoom, there's a chat function. If you don't see the chat function, there may be another, it says more on it with 3 little dots. If you press that, you'll get to the chat function. So anytime during Dr. Ojemann's presentation, please, if you have questions, put them in the chat. Tammy is going to keep track of all those. And at the end of the lecture, we're going to ask those questions. We probably won't get to all the questions with so many people, but we'll answer as many as we can. And we promise over the next couple of weeks, the questions we don't answer, we'll try to answer by email. So we're going to try to stick, again, respect everybody's time and try to stick to the 1 hour. With that said, I'm going to go ahead and introduce Dr. Ojemann. Dr. Ojemann is professor of neurosurgery. He's director of the stereotactic and functional neurosurgery program here at the University of Colorado. He also was director of the medical school neuroscience program for many years, and he gave one of the probably most enjoyable lectures, at least from the medical students' reports, on neuroanatomy, on brain anatomy. So we're privileged to have Steve give us this lecture today. Steve, thank you, and I will stop sharing here.
Thank you, Kevin. Okay, Kevin, you'll let me know if any problems seeing my screen or hearing me, please.
It looks good.
Great. Well, thank you for that introduction too. And what I hope to accomplish in the next half hour or so is a brief introduction to the structure and function of the central nervous system. And so a good starting point is to define what do we mean by the central nervous system. Essentially, we're talking about the brain and spinal cord. And so the nerves that emanate from those structures out to the body and the nerves that come from the body into those structures are the peripheral nervous system. And when we talk about the brain and spinal cord, you can see that this is, at least in the spinal cord, you can appreciate how highly segmented this is, that there are multiple segments where nerves come into and out of the spinal cord. And you have 31 pairs of spinal nerves in the body. And then there's another 12 pairs of cranial nerves that are coming into and out of the brain and the brain stem. And that's how information gets to and from the body to the central nervous system. And so if we want to define some of the terms here, we can look here at the brain, and you can see that it's got the spinal cord then below it. And everything above the brainstem we'll call the cerebrum. Below the cerebrum, there's a smaller structure, the cerebellum, that's attached to the part of the brainstem. The brainstem itself, and then the spinal cord. And so these are the elements of the central nervous system. And again, the nerves are coming into and out of these peripheral nerves. And so nerves taking information from the body, enter the spinal cord and ascend to structures within the central nervous system where they relay information. And then information coming out of the central nervous system leaves through nerves to get to things like skeletal muscle. And so I mentioned that the central nervous system is highly segmented. And in fact, our whole body is highly segmented, that you can appreciate this in the embryo more than you can in our adult form, but we're very much like earthworms or insects in terms of how our bodies are highly segmented. And you can see some evidence for this when you look at the sensory information from the body and how it travels to the nervous system. And so if you map out each part of the body in terms of what nerves relay information from that area to the central nervous system, you get something that looks like this. And we call these the dermatomes. And essentially they correspond to different nerves entering the spinal cord at different levels. And we could construct something similar for the information exiting the nervous system in terms of what muscle groups each nerve supplies. And we can, again, if we trace it from the embryo, see that that's a highly segmented organization. And here's what the embryo looks like about 3 weeks after fertilization. You can kind of see these segments. Each of these little blobs on the side of the midline is a group that's going to become some of the muscle, and some of it's going to become those patches of skin, and then a corresponding part of the structures here in the center are going to be the central nervous system components that innervate those segments. And really what I want to show you here is that in those first 3 weeks, this embryo starts as a flat disc and it folds over itself to form a hollow tube. And here you can see a cross section of that hollow tube. And that hollow tube is the central nervous system. And so everything that we described in terms of the brain and spinal cord is really just a hollow tube that obviously gets quite a bit bigger at the top than it does at the bottom. The spinal cord still looks like a tube. The rest of the CNS doesn't so much because it grows a lot and elaborates. And we'll go through some of that. Here's what some of that growth and elaboration looks like. And here's the period after fertilization that takes place. Now we're just looking at the top part. You can see all of these convolutions and mostly this expansion here at the very top. It's like two large balloons inflating off to the side of the midline. And those two large balloons are going to become the cerebral hemispheres. You can see them start to now look like what we know the brain looks like in the adult form. It kind of folds around itself, forms this big groove here. This is called the lateral sulcus or Sylvian fissure. Separates the frontal lobe from the temporal lobe mostly. And then you can start to see these hills and valleys start to form at the end of gestation. And those are going to be the gyri and the sulci. So a gyrus is the hill and the sulcus is the valley of the surface of the cerebrum. And so that's all to say that this hollow tube grows into these adult structures. And what's the importance of that hollowness of the tube in the adult structure? Here's a transparent view of the brain seen through the skin. And then we have different sections, different ways of slicing the brain. This is a good point to make early on, is that we have conventions about how we talk about slices of the brain. And so as shown here in this top left corner of these slices is what we would call a coronal or frontal section. It's like we're slicing the brain this way and looking face on. And then here is what's called a sagittal section. That's as though we're slicing in the plane of this image. And then here's an axial or horizontal section. That's as though we're slicing this way. And so you're looking at sort of a salami slice of the brain, if you will. And the point is that this hollowness is still present in the adult structure, and that's preserved as these cavities in the center of the brain that are outlined in blue. And those are called the cerebral ventricles. And those ventricles are fluid-filled cavities that are filled with cerebrospinal fluid. And so this is what a casting of the ventricles would look like. And this is what cerebrospinal fluid is. It's produced by these special structures in the floor and the roof of the ventricles called choroid plexus. And what that choroid plexus is doing is producing essentially an ultrafiltrate of your blood. So your arterial blood sends branches into the choroid plexus, which filters it and creates this clear fluid, the cerebrospinal fluid, that circulates through the ventricles and then ultimately exits the ventricles through 3 small holes at the base of the brainstem. And those 3 small holes then allow the cerebrospinal fluid to circulate around the brain and the spinal cord. And then ultimately it's reabsorbed by the body in these large veins that are on the inner surface of your skull and that drain the blood from the brain. And so those veins, the main one here is called the superior sagittal sinus, runs down the midline. And the cerebrospinal fluid has to get reabsorbed. It has to exit these holes and it has to get reabsorbed because you're constantly making it. And if you stop reabsorbing it, or if it can't circulate past an obstruction, then it's going to just accumulate and cause a problem. And I'll show you that problem. That problem is called hydrocephalus, or water on the brain. And the reason it becomes a problem and can become one quickly is because you have about 150 cc's in your body at any one time. So that's about half a soda can. But you make about 500 cc's in a day, and that's almost 3 soda cans. And so you're turning this over many times a day. And if it's being made but not being reabsorbed by the body, then it becomes problematic. And this is what that problem can look like. So these are axial sections. These are those salami slices of here's a normal brain on the left, and you can see what the normal appearance of those ventricles is. And here's one where there's been an obstruction and accumulation of that fluid. And so these are severely enlarged ventricles, and this is hydrocephalus. So what do we do about this? We can drill a hole in the skull and put a tube in. It actually goes through a little bit of brain tissue. It usually doesn't cause any problems. And then drain that fluid to the outside. Or another thing we can do, depending on what the nature of the problem is, if it's an obstruction, let's say that those outlets at the base of the brainstem aren't letting the fluid out, it's being produced but can't exit the brain, then we can sometimes put an endoscope into the brain. We drill a hole, we put the endoscope then through some normal brain tissue. Again, that usually doesn't cause a problem. And then we can see in the ventricle, and we can actually make a hole at the base of the brain where it becomes very thin and create a new pathway for this spinal fluid to flow. And that's one procedure for treating hydrocephalus. This is what that looks like. And so here's an endoscope inside the ventricle. Now you can see that that pink stuff there that looks like cauliflower is the choroid plexus. That's the structure that's making this cerebrospinal fluid. And you can see by the fact that we can visualize all this stuff, how crystal clear cerebrospinal fluid is. And so this is down at the base of the brain where we're going to make that hole. I don't think I have that on the video, unfortunately, but that's just a view inside the cerebral ventricles. But let's come back now to the outside of the brain, and we can start to identify some surface anatomy and talk a little bit about some of the anatomy here. And now this is called a coronal section. So this is a slice as though we've cut the brain this way and we're looking essentially face on here. Normally the eyes would be here, the ears would be about here, and then this is the cerebrum here. And so on the surface, again, we can see those hills and valleys. The hills are gyri, the valleys are sulci. And a deep sulcus we sometimes call a fissure. And so there's one deep sulcus here that's called the central sulcus, or the Rolandic fissure. And that separates the frontal lobe in front of it from the parietal lobe behind it. Another deep sulcus is called the lateral sulcus, or Sylvian fissure, and that separates the frontal and parietal lobes above it from the temporal lobe below it. Here's what it looks like on that section. You can see that lateral sulcus, that Sylvian fissure, separating the frontal lobe above it from the temporal lobe below it. And then deep down, there's another lobe here that's called the insula, or insular lobe. And so that's sort of buried underneath these other lobes, and that's why it's called the insula. It's insulated by it, if you will. And then finally, in the back, we have the occipital lobe, which probably is well known that that's important for vision. And we'll talk about that. Now, if we look at this coronal slice, it's pretty apparent that some parts of it are gray and some parts of it are white. And that's useful because they're referred to as gray matter and white matter. And so those terms, I think, are pretty commonplace. But let's explore what they mean. So you have gray matter, and then you have white matter. And white matter, typically, the term that should be associated with is myelin. And so myelin is a lipid that some special cells called oligodendrocytes, they coat parts of the neurons with myelin, and that insulates them and increases their conduction speed. And so that insulation looks white on a gross specimen, and that's what the early anatomists saw, and so they called it white matter. And so this white matter pathway is, in fact, the cabling of the nerve cells wrapped in myelin. And so if we look at a nerve cell here, this is a neuron, and it has this part here, this fat part, the cell body, and that's got a nucleus in it. And it's got all these twiggy things, those are called dendrites. And then usually all neurons have a single axon that leaves the cell body and carries information away from the cell. And that's what gets wrapped in myelin. And so gray matter is gray because it's where all the cell bodies are concentrated. And white matter is white because that's where all the cables, the axons, are found. And so white matter is really where all the cabling is. Gray matter is where all the cell bodies is. But they're attached still. They're all part of the same cellular structure. And so this is what gray matter looks like when you stain it and look at it under a microscope. And so it's got each of these little stipples is a cell body that's taken up the staining. You can see sort of below it that that's fairly sparse in terms of the cellularity. But notice here, this particular part of gray matter has a pretty structure. And if you kind of squint, you can kind of see horizontal layering to those cell bodies. And that's characteristic of the cerebral cortex. And so what's the cerebral cortex? The word just means bark, basically, in Latin. And so it's the outer bark of the cerebrum. And so it's about 5 millimeters thick, and it's characterized by those cell bodies that are arranged in those layers. And most of the cerebral cortex has 6 distinct cellular layers. And that has to do with, that architecture has to do with how it's interconnected and how it processes information. And so that's one component of the gray matter. Now, there's also other gray matter structures besides the cerebral cortex. And so one of them is shown here in orange. That's the thalamus. And so thalamus, the word in Greek means inner chamber. And so you can see how the cortex is on the outside. The thalamus is deep on the inside. And so it's the inner chamber, or bedroom is another translation of that word. And so that's another important gray matter structure. And as you would imagine, that's also where all the cell bodies are concentrated. And then the axons leave the thalamus to go elsewhere. A lot of them go to the cerebral cortex. And so there's other gray matter structures called the basal ganglia. We don't have a lot of time to get into all of that, but you can see some of those structures here. These are just a variety of clusters of cell bodies that then send their axons here and there within the central nervous system. And so this is now, if we dissect out the gray matter, the cerebral cortex, you can see some of that white matter. You can see how even in a gross specimen, it looks like cabling. It looks like fibers that are transmitting things from point A to point B. We can even image these fibers in the living person by using a technique called diffusion tensor imaging. It essentially can detect signal changes created by the flow of water molecules through some clever physics. But basically, what you're seeing here is the different directions that water molecules preferentially flow, and those correspond quite well to known pathways within the white matter. And so fiber imaging through diffusion tensor imaging is a useful technique. Okay, so let's move on a little bit. Here's that cerebral cortex gray matter again, and those 6 layers I mentioned. Again, each of those is a cell body, and just again, you can see how it's pretty loose layer here, and layer 1, layer 2 is more dense, layer 3, a little less dense, layer 4 is pretty clear and dense, and then 5 and 6. And so what some of the early anatomists noted when they did this in different parts of the cerebral cortex is that layering looked different in different parts of the brain. And so if you take that from the back of the brain, which is the main visual area of the brain, you notice that layer 4 was really dense. And it turns out, as we dissected this out further, we found that layer 4 is where most of the inputs from our 5 senses end up. And so they end up in layer 4. So a sensory area of the brain is going to have a big layer 4. And then other areas like here, the motor area of the brain has a different architecture where layer 5 is particularly prominent. And that's not surprising, where the outputs from the cerebral cortex go to other structures. And so this structure has a functional significance. But for now, just realize that we can see structural differences within different parts of the cerebral cortex. And the anatomist who did most of this work and whose name got associated with this is a German anatomist named Corbinian Brodmann. And this is the map of Brodmann's areas. And he defined 52 different areas that differed in their layering. And it turned out they had very strong correlates with the functional connections of those parts of the brain. So that area 17, again, is the primary visual cortex. Area 4 here in the back of the frontal lobe, just in front of the central sulcus, is the primary motor cortex. And we can say things about other areas of the brain, and I'll use that system for describing them. So let's talk about the primary motor cortex. We saw that central sulcus at the back of the frontal lobe. And if we look at the gyrus just in front of it, turns out if you electrically stimulate that gyrus, you'll cause muscle contractions on the opposite side of the body. And if you have a stroke or trauma or a tumor or a lesion there that destroys that tissue, you'll end up with weakness on the other half of the body. And something similar happens for the areas just behind the central sulcus, except that instead of weakness, what you get if you damage that area, that post-central gyrus, you get numbness on the opposite side of the body. And so that's purple is the primary somatosensory cortex. It's a part of the brain that's critical for the experience of sensory information on the opposite side of your body. And so if we look at a coronal section again here, we can see not only does that cortex have importance for movement on the opposite side of the body, but it's actually mapped out in a specific way so that the part down here near the lateral sulcus is important for movement of the face on the opposite side of the body, whereas the part up higher here is important for movement of the hand. And then if we go down in between the two, you can see the two cerebral hemispheres here connected by this band of white matter called the corpus callosum. And in between those two is the area where the cerebral cortex is critical for movement of the leg. And so that mapping we call somatotopy. And there are several different functions that map in different parts of the nervous system in a somatotopic way, meaning the body is mapped out. And it's a distorted mapping, right? You have a lot more room on your cortex for your hand than you do for your elbow. That kind of makes sense because you need more control surface for your hand than you do for your elbow in general. And so this is an important clinical point in that any damage to the cerebral hemisphere that involves the primary motor cortex is going to produce what we call hemiplegia, which is weakness on half the body, or paralysis is a bit more colloquial term for that. But basically, it depends on what part. If the whole thing is damaged, then the whole half of the body will be weak. If it's just down here, then maybe just the face on the other side will be weak. And so that's a critical clinical part. Sort of related to that, maybe you've seen this before, but again, we take that section and we map out that somatotopy on both sides, and then we kind of reconstruct it as a human figure. It looks kind of like this distorted human figure that has big lips and big hands because those are more represented on the surface of the brain. That's called the homunculus, and that's still, I think, a useful way of thinking about the representation of the body on the brain surface. So that's what lesions do to the motor part of the brain. A lot of what we came to understand about the way the brain is organized came from the study of other kinds of strokes and lesions. The early anatomist here in the 19th century, this was Paul Broca. He was a neurologist who studied a group of patients who'd had strokes that left them with the ability to articulate noises, and they could vocalize certain noises, but they couldn't produce meaningful speech. And so even though they had the ability to move their mouth and to make sound, they couldn't organize it into meaningful speech. And so he studied these patients, those that succumbed. He looked at their brains and found a consistent pattern of injury in patients who had that phenomenon. And so here's a brain specimen that he looked at. There's the central sulcus, and there's the lateral sulcus. And so it's this area here in purple that was damaged. Sorry, it's a little bit off on my graphic, but it's called Broca's area. And it's basically in the inferior part, the lower part of the frontal lobe, just above the lateral sulcus. And he found it was also only on the left side of the brain. And so what's important about this is, one, he found a spot that was critical for just the production of language. In many cases, these patients could still understand things that were said to them or written to them, but they couldn't produce meaningful speech or writing. And so it was a specific function of language, and it also showed this idea of hemispheric dominance, that language function was represented, he found, on the left side only. Now, it turns out that there are a minority of people who have language function on the right side of their brain, and some for whom it's both sides of the brain. But the numbers are about 1% of right-handed people will have right-sided dominance for language, and the rest it's on the left. And in left-handed people, it's still about 70% who have left-sided language function, and it's only 30% where it's on the other side. But that's the concept of hemispheric dominance. And there are some other functions that are lateralized in that way, where one hemisphere does more than the other for that particular function. And today we would say that Broca's area is really not so much a area that magically produces language, but it's part of an interconnected network. And it just happens to be a node where all this information that comes from many other parts of the brain funnels into a discrete enough area that damage to that area interrupts a fairly broad variety of those functions. And if you have an injury in another area, then the deficit is more subtle, but it's still doing things to your language processing. But so that's what we would say today, is that it's an important node in a more distributed network within the brain. So let's talk a little bit more about lesions and what they've led us to discover about the brain. And so sometimes the lesions are created by surgeons, and that was the case with this patient. He was a fairly famous patient who, for his life, he just went by his initials, HM, and then after he passed away, about 10 years ago, his name was revealed, and it was Henry Molaisian. He was a patient who had severe epilepsy, and at the time, it was known that the temporal lobe was important in epilepsy, and the inner part of the temporal lobe, especially a part called the hippocampus. And it's called that because that's the Greek word for seahorse. And if you dissect that out and look at it in just the right way, it looks like a seahorse. And so at the time in the 1950s, wasn't exactly known what the hippocampus was doing. And so his surgeon, famous surgeon named Scoville, took out both hippocampi. And so he took out this part of the temporal lobe on both sides in an effort to treat the patient's epilepsy. But what was discovered is epilepsy, in fact, was not unfortunately treated. And also he was left with a very severe deficit that was discovered. And that was he couldn't form new memories. And so essentially the essential importance of the hippocampus in forming new memories was something that was discovered through this. And then probably the most famous lesion patient was Phineas Gage. He was a railroad worker in the middle of the 19th century who was using a big rod to tamp dynamite into some rock, and then the dynamite exploded and the rod went through his face and brain and came out the other side. And his coworkers were rather stunned that he was still able to walk and talk, and essentially, except for not being able to see in that eye, was more or less normal to outward appearances. But then when he got medical attention and was studied as time went on, they found that he actually had a pretty severe deficit that wasn't in his sensation or his movement, but it was really in his ability to function in social situations and able to inhibit his behaviors when they were inappropriate. And so he would urinate in public, he would laugh inappropriately, he would be vulgar inappropriately. He was, as his neurologist described him, fitful, irreverent, obstinate, and capricious and vacillating, and no longer himself. And so the role of the frontal lobe in the structure of personality and controlling our behavior was something we learned from Phineas Gage. So lesions have taught us a lot about how the nervous system works, but they can really only go so far. And so if we really want to learn more about the nervous system, we have to look at how does the nervous system generate these functions. And so to do that, we have to think about the brain as an electrical organ. And to do that, I think it's better to start with a simpler electrical organ in the heart. And so, you know, we all know that the heart has this tracing that we can record from the chest wall, which is the electrocardiogram, or EKG. And what that is basically a measure of the synchronized activity of many thousands of cardiac cells. And those cardiac cells are themselves electrical cells that discharge. And what I mean by that, we have to go down a path we really don't have time for, but it's essentially the flow of ions across a membrane that isn't permeable to those ions, and they have to flow through specific protein channels in the membrane that are highly controlled. And so basically the cell spends a lot of energy to pump these ions out and create a dam of all this energy stored up, and then it'll open these channels and let that dam flow through in order to have electricity flow across the cell membrane. And in the heart, that conducts in a very regular way so that the electricity leads to muscle contraction. And that muscle contraction has to be coordinated if the heart's going to work properly. And really something similar is going on in the brain. Here's a kind of cartoon of that electrical activity being conducted across brain cells. And from the surface of the scalp, you can record brain waves that are really the averaged activity of many thousands of nerve cells discharging. And so the question is, well, how are these nerve cells getting so coordinated that you can get this rhythmic activity on the surface of the brain? And this is the electroencephalogram, or EEG, and another animation of it. You can also look at it in terms of how synchronized it is. You can color code areas that are more synchronized than others and see how that synchrony shifts and changes over the brain. And here's what the EEG looks like compared to the electrocardiogram. But really, the question of how do things synchronize, about the volume, is best understood through this metaphor. And this is an image from the Millennium Bridge, which opened for the millennium in the year 2000 over the River Thames. And if you think about each person stepping on this bridge as a neuron, and every time they step, that's a neuron discharging its electricity, then what you see here is that if a few people start discharging at the same time, and they all share a common base, then the whole base can start to shake, and that shaking can in turn get more neurons discharging in sync. And it becomes this kind of cycle where the shared base starts to oscillate, and it brings other neurons into it, and the oscillation gets bigger. And so in this metaphor, the bridge is the EEG, and the people are the neurons. And what's the shared space in the EEG? It's the electrical fields. It's just the electrical milieu that all these neurons exist in. In between the neurons, there's this extracellular space, which has charged particles in it. And so as those start to fluctuate, they'll bring more neurons into them, and everything starts to synchronize. And that's a tendency of brain cells, is to synchronize with each other. And you can ask, why don't these synchronizations go out of control and just keep going? And that's what happens when you have an epileptic seizure. But the reason you don't most of the time is that you also have other neurons that inhibit cells. They basically come up to one of these people and stop them from walking. They put their hand on their shoulder and say, you got to stop walking. And so about 20% of the neurons will inhibit their partners, and that will balance the thing so that the brain can go into and out of synchrony. And so I'm just going to take a couple more minutes to talk about this synchrony, and then we'll conclude. And in general, you can say things about the frequency of these waves and how they relate to behavior. And obviously these waves are different in different parts of the brain at different times, but in general, we have these rhythms that are a little bit faster when we're awake and working, and that the rhythms tend to slow down when we slow down and when we're drowsy or sleeping or dreaming. And again, that's a very complicated topic that changes in different parts of the brain. But here's what that synchrony can do when we measure it from that motor cortex of the brain. Here we've got very small electrodes on the surface of the brain, right at the motor cortex, fine enough that we can detect synchrony in the parts of the brain that control individual fingers. And this is from my friend Kai Miller, who's a neuroscientist and neurosurgeon at the Mayo Clinic. And this is what we would call brain-computer interface based on the EEG. And what he's seeing is that this is the subject's hand, and they're either moving their index finger, their ring finger, or their thumb. Sorry, their middle finger or their thumb. And then the EEG is classifying the signal, the synchrony it's measuring from that area into one of those movements, and it's transmitting that to a robot to have the robot do the same movement. And so you can imagine this would be useful for a neural prosthesis for someone who had either an amputation or a spinal cord injury and was no longer able to physically move the hand, but could still generate the electrical signals that move the hand. So that's an example of the EEG. And then I want to spend the last maybe 2 or 3 minutes just talking about these components that generate this synchrony. And the main one is the neuron. And what we know about the neuron came from the early anatomist. Here's Santiago Ramon y Cajal, who was a famous neuroanatomist at the end of the 19th, early 20th century, who described the parts of the neuron and made very prescient guesses about how the neuron worked. And essentially what he described was this cell body, these dendrites, the little twigs I showed you, and they generally have these little knobs on them, you can see here, and then the axon. And his idea was, from this structure, he inferred that information probably flows electrically in a single direction through the cell. And so information, he surmised, would come into the cell through the dendrites, and then it would leave the cell through the axon to go somewhere else. And that, we called that the principle of dynamic polarization. And others who studied the electrophysiology found out that that was mostly true. And then when the axon ends, and that electrical activity ends at the axon, there's usually an enlargement there. And that axon is usually connecting to then a dendrite of another neuron. And looking closely at that connection, other early physiologists, and the most notable one here who named it is Charles Sherrington, and he called this the synapse, and that's a Greek word for clasp or a handshake. And that's where the neurons communicate with each other, not electrically, but they convert the electrical signal into a chemical signal. And so what happens, just as the electrical discharge causes cardiac cells to contract, the neuron, the electrical signal when it arrives, causes the neuron to release these vesicles that are holding stores of a chemical that'll then diffuse across the empty space between the cells and bind to receptors that are usually proteins in the next cell. And that binding then can create a variety of different effects. Often it creates an electrical discharge wave that then can propagate through the neuron. And so if it does that, it might excite the cell, or it can make it more difficult for the cell to become excited, in which case it'll inhibit the cell. So it's the nature of the receptor that determines what the effect is on the next cell in the chain. And the neurotransmitter binds to that receptor and starts the effect. And so the main neurotransmitters, the most common one in the brain is called glutamate, and it mostly does excitation. And then the second most common is called GABA, and it mostly creates inhibition of its neighbors. And that's that balanced excitation and inhibition that I talked about. And so these transmitters bind to their receptors and create effects. And this is tremendously important in the world of neuropharmacology. Some of these receptors you've heard of, serotonin, and drugs like Prozac deal with serotonin and its effects in the synapse. Dopamine, acetylcholine, all of these are different kinds of neurotransmitters and important areas where we can modify things pharmacologically. And so the last point I'll make about synapses is these are not static connections between cells, but they can change and evolve based on factors like experience. And so this is really how the connections between neurons can change with learning. And it has to do with growth that follows certain patterns of electrical activity. And without getting too much into it, the person who's generally credited for describing this phenomenon was a psychologist from the middle of the 20th century, Donald Hebb, and his phrase that neurons that fire together wire together really encapsulates this idea of synaptic plasticity. And one of the final points I want to make is that there's other important cell types in the brain besides neurons, and they're the glial cells. In fact, there are 10 times more glial cells than there are neurons in the brain. And the one type I'll talk about here is called the astrocyte. You can see them up here. They look like little stars, and that's where the name comes from. And they have an important relationship in that these little star-like processes, they wrap around the synapse, and they also wrap around the capillary, the blood vessels that are bringing blood to the brain. And that connection between the synapse and the capillary allows the astrocyte to respond to a lot of function, a lot of neurotransmitter being released by changing the local blood flow. So it basically mediates, if it senses a lot of neurotransmitter, it changes the diameter of this capillary, it allows more blood to flow there. And that coupling is something we can actually image in a technique called functional MRI. And this just demonstrates that technique in a simple animation. When the subject moves their thumb, an area that has a lot of synaptic activity is that motor cortex. And you'll see changes in the signal because it turns out that you get changes in your hemoglobin concentrations when you have more blood flow, and hemoglobin is a magnetic substance. And so oxygenated and deoxygenated hemoglobin have different signals. So without getting too complicated, just know that there's a signal change associated with that blood flow alteration. But if you measure it from a different part of the brain that isn't showing a lot of synaptic activity, you don't see any change in the signal. And so you can then use a statistical map to identify that area as an area that had a change in blood flow. And that's called functional MRI imaging. And it's because of the astrocyte mediating this, what we call neurovascular coupling in the brain. And so I'll just leave it with this, try to put it all together. Let's just talk about the visual networks in the brain. You have in your eyeballs these specialized receptors that are a lot like neurons. And when they detect photons, they change their electrical discharge. They have synapses and neurotransmitters that then relay those to other neurons. Here in the thalamus, that inner chamber. And from the thalamus, we can look at some DTI, the diffusion imaging that shows those fiber pathways going to Brodmann's area 17, the primary visual cortex. And within that cortex, there's networks of neurons that are all communicating and synchronizing with each other. And we can, in fact, measure the synchronized activity that is associated with visual perception. And we can also look at, if we image a patient while they're looking at a complex image versus when they're looking at a blank screen, we can see the difference in blood flow, measure that on functional MRI. There are other techniques that can measure blood flow, and we can image those changes in flow. And we can map out networks like this for the visual system, for the auditory system, for all of the senses, for motor cortices, for memory, and even for higher cognitive functions. So I think that's a good point to end on. Hopefully we still have some time for questions. So thanks very much for your attention, and happy to answer some questions.
Well, Steve, thank you very much. That was terrific. We've got exactly 10 minutes left. So I think we've got some time for questions. Tammy, I'm going to turn things back to you.
Okay, we have some great questions. The first one is, what are some symptoms somebody might have if they have hydrocephalus? What might they experience?
Yeah, so good question. So hydrocephalus, sometimes it evolves quickly, sometimes it can evolve more slowly. If it evolves quickly, especially, then the brain doesn't really have a chance to compensate and accommodate for the increased amount of stuff that's in your cranium. And so your skull is rigid, right? It's not going to balloon up or expand. But if you've got this excess fluid accumulating inside the brain, then the only thing that can happen with that increased volume is for the pressure to go up. And so the intracranial pressure is a really important concept. And if that goes up too high or too quickly, then you can get such a high pressure that blood can't flow into the brain, and you can end up having a stroke. From that, you can also start to force the brain across some of the anatomic boundaries that constrain it. And that forceful displacement you'll hear about probably in the trauma lectures, that's called herniation, and it's a very dangerous thing, and it can result in severe disability and death. And so hydrocephalus, it tends to cause the symptoms of intracranial pressure elevation or headache, nausea, vomiting, and then lethargy and coma if it progresses to a severe form. Now, if it evolves slowly, the brain can start to compensate. There are fluid shifts within the brain, and the brain can actually tolerate a fair amount of increased spinal fluid by, again, if it's gradual, by displacing its own fluid to other parts of the body. Good question.
There's a lot of questions, and we're not going to get through them all. And just so you know, Dr. Ojemann is going to be given homework to answer all the questions, and then I'll send that out via email. But the next question is, how does making a new hole to let the cerebral spinal fluid drain not cause a cerebral spinal fluid leak?
Yeah, good question. So I didn't have time to get into it, but the entire cerebrospinal fluid volume is encased within these covering membranes over the central nervous system. And the whole brain and spinal cord are covered by these membranes, and they're called, the pia is the innermost one. That's just a thin layer like cellophane over the brain. The next is called the arachnoid, and that's a bit more spindly layer where all the CSF circulates. And then on top of that is the dura, which is a harder, more leathery covering of connective tissue. And so as long as you're still within that space, you know, that's what a CSF leak is when cerebrospinal fluid can get out of that containment system. And what we're doing is staying within the coverings of the brain and just making a hole so that the spinal fluid can get out of the brain and circulate within those membranes to get to the veins. And the veins actually have little impressions from those membranes into the veins, and they're specialized impressions. They look like sugar granules when you're looking at this in an anatomy lab. And those granules, they basically poke into the veins so that the spinal fluid can now move just by, essentially by osmotic and hydrostatic forces into the venous system. And so what we're doing when we make that hole is we're just basically trying to create a new channel to allow fluid to flow when it's been blocked by, say, a tumor covering those other channels. It doesn't work for every kind of hydrocephalus. Sometimes hydrocephalus occurs because the veins themselves have clotted off. And so you're not going to fix that by making a hole in the base of the brain. You need to treat the clot in the vein so that the vein can reabsorb the fluid. I hope that helps. That's getting into some tricky concepts.
So Steve, I'm going to interject just real quickly. There was a quick question about what is slow buildup of fluid versus quick, and basically to build up fluid over hours to days is considered quick. If it's weeks to months, it's considered slow.
Right. Yeah. Good.
The layman's term inflammation. What is this, and what does it look like in the brain?
Yeah, excellent question too. Another thing I just didn't have time to get to. And so those glial cells, I just talked about the astrocyte, and I talked very briefly about the oligodendrocyte. That's the one that wraps the nerves in myelin and makes white matter white. Another one is called the microglia, and that's essentially the immune cell of the brain. And it's actually derived, like most other immune cells, from your bone marrow and not from the embryologic structures that form the neural tube. And so it gets there from the outside, and that's a major mediator of brain inflammation. And so a lot could be said about this, but basically you can have infections of the nervous system and viruses, bacteria, fungi, and parasites. The brain is a little special in that its blood flow is different than most other parts of the body. And if I can return quickly to one slide, let's see if I can do this without causing a problem. I still share my screen. Remember this slide? So there's that capillary, and that the capillaries in the brain, and because they're surrounded by the astrocyte too, they're different than capillaries in a lot of other parts of the body. Most other organs, the capillaries are pretty leaky, and cells and proteins can pretty freely move in and out of the bloodstream into the organs, like the liver and so forth. But in the brain, that's not true. That's called the blood-brain barrier. And it means that most molecules above a certain size are not able to get into the brain. They have to have special transport mechanisms to get in the brain. So the brain is pretty picky about what it lets in. And so that means that also in terms of its immune system, it's pretty different from the rest of the body. And that's about all I can say about that. I think you're going to have lectures from people that are going to go into that.
We will.
Does heat or elevated temperature affect brain function?
Yeah, absolutely. And let's maybe just start that, when you have a fever, you probably notice that, your thinking is different. Most functions in every part of the body are pretty sensitive to temperature, and that, we as humans tend, and all warm-blooded animals try to keep their temperature in a pretty limited range. And as you get too high, then you can start to see problems with fundamental cellular processes. We deliver pretty high heat to areas that where we want to make an ablation. If we have a part of the brain that's not functioning properly and we need to destroy it, we often will use heat as the way of doing that. And we know very well at certain temperatures that there's a reversible heating that can disrupt the brain's function, but it'll come back to normal if you turn the heat off. And then there's certain temperatures where it'll irreversibly change the function, and it won't come back afterwards. And so those aren't usually temperatures you'd encounter, physiologically, even when you have a fever. But even the temperatures, 40, 42 degrees centigrade can definitely alter brain function.
Is there any evolutionary or developmental explanation for why certain characteristics are left versus right brain?
It's a great question, and there's many theories about this that I don't think any of them can really be said with any certainty to explain why we have this hemispheric asymmetry, and also why is the nervous system sort of crisscrossed the way it is for certain things, like, you damage the right side of the brain and the left side of the body is where you see the problem. And so that crossing of fibers has sort of defied an easy explanation. And so I don't know that I can really expound on any one particular theory. Part of it, if you can accept that some handedness developed early on, and that most of us are right-handed, which means the left side of the brain controls our right hand, and that's where we have more dexterity. So maybe there was more motor territory applied there, more investment in the motor system on the left side of the brain, and maybe that's why language came from that. There's a lot of relationship between gesture and language, obviously, and so it may be that some of the early communication functions were really more gestural and more just people using their hands and the dexterity of their hands to communicate, and then that was translated eventually to our mouths and our lips. And so that's one theory that's been expounded. There are many others, and I think in the end, I don't think any one of them is totally compelling.
Okay, so one last question. What can weaken neuroplasticity or block that process?
Yeah, also a very good question. Much of neuroplasticity is experience dependent. And so there's a lot of use it or lose it qualities to the brain. And I think, some of the studies, and you'll probably hear about this when you hear about degenerative diseases and dementia, is that there are number of factors that predict that, including being sedentary is a risk factor for dementia, and exercise seems to be protective against many kinds of degenerative diseases. And I think that's a bit of the use it or lose it kind of phenomena, that the brain is an electrical organ, and it's very, its electrical activity is intimately related to its growth functions. And there's some ways that that's understood, and a lot of ways that we don't understand. But basically, areas that are electrically active and that are involved in learning often see the most in terms of growth and enlargement and new, not only synapses being formed, but there's even neurogenesis. There's even new nerve cells formed even into adulthood. And that all seems to be something that can be stimulated by experience. Some experiences may not be as good as others. There are certain, like epilepsy, where there's too much electrical synchrony in the brain that can actually damage nerve cells. And so it's not that all electricity is good, but some does appear to be. And there's even some studies looking at when electricity is delivered from the outside through the cranium into the brain, that can improve performance and demonstrate growth within that part of the brain.
So Steve, I think it's fair to say as well that our plasticity of the brain decreases as we get older as well.
I can say for sure that,
yeah.
100%.
So I think we've run out of time. Steve, thank you very much. That was a wonderful lecture. We didn't get to a whole lot of questions, but as a group, we'll work on trying to answer these and get them back to people. So a week from now, we're going to talk about stroke and traumatic brain injury, as well as a traumatic brain injury overview. So thank everybody for attending. Good night.
Next week.
Thank you so much.
Thank you.